This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson, and it's my pleasure to have with us tonight Dr. Lee Hyer. Welcome, Dr. Hyer, and Dr. Hyer is going to discuss some of the nuances of memory. Is that correct, Lee?
If I remember so.
That's right, yes. And so we've actually had conversations before, and I know that in many ways you devoted your career to the problem of preservation of the geriatric brain. Is that a fair statement?
Yes.
And you were discussing this a little bit earlier, that you were going to Johns Hopkins and you were doing some work there. What was that all about up at Johns Hopkins?
Yes, well, CMS, Medicare, Medicaid, has in the last 5 years seen that medications make a little difference and not a big difference.
Yes.
And so the effort has been consistently in the last 5 years to show people that there are things that you can do with people who are older,
yes,
have memory problems, have a little bit of depression,
yes,
a little bit of
yes,
anxiety,
yes,
and a little bit of pain,
yes,
that involve psychosocial interactions and
yes,
interventions, not just medications. Medications have a cost benefit, as you know, and
yes,
the cost is becoming increasingly problematic, and people are very aware of that now. And so it's very typical for people to come in to see me and say, what can we do for my mother?
Yes.
I don't want to put her on medications. That's
yes,
a very common response.
Yes. And there are different kinds of medications that act in different ways. I mean, I guess there's at least some medicine out there that's used for people that have Alzheimer's or have that diagnosis, which is a difficult diagnosis to obtain, is it not?
Yeah.
I mean, Alzheimer's is a diagnosis of actually Dr. Alzheimer, and he was a German neuropathologist in the first part of the 20th century. As the Germans would want to do, they're very, if I can say that, very compulsive scientists, and he was slicing brains of demented people and found these plaques, and then thus the term was established. But to making that diagnosis is complicated, is it not?
It is. It's a diagnosis of exclusion, and by definition, it's a diagnosis that can only be given at death, and it's a viewing of the histology of the brain. And you will see the plaques and tangles that you
yes,
noticed and indicated. And it's just about 100 plus 5 years now that this diagnosis was discovered. And when I was at Duke 100 years ago, we would see patients come in who were in prototype younger, a female who was about 80-ish, who could not remember her name but was very socially skilled.
Yes.
And that person might live 3 to 4 years. Now things have changed totally.
Yes.
People are getting the dementia diagnosis, one type of which is Alzheimer's diagnosis, earlier, and they're keeping this diagnosis for 15 to 25 years. We have people in data sets at Robert Wood Johnson who have been in there for 27, 28 years. It's a long time to have memory problems. It's a long time to have difficulties with interactions and social adjustment and the like. So, we're getting better at diagnosing what Alzheimer and dementia is, but we don't have good treatments, and that's what we've been doing at GNI and at Family Medicine at Mercer.
Yes.
Try and come up with ways in which we can use the medication, but not exclusively, and in some cases not use it at all, to use other methods to train the brain.
And there's lots of experimental work underway with different markers for Alzheimer's. People are doing different kinds of, doing a lumbar puncture, seeing if they can pick any markers up for the disease. So that's quite a task. Because I think the problem that you've alluded to is that as we try and preserve mentation, in our senior citizens, of whom I think we both are in the senior citizen category. But preserving the mentation is difficult. And if we can have some markers for the disease we're treating, that makes it a lot easier. Yeah. Because we're dealing with a multifactorial problem, are we not?
Oh,
so
yeah.
As the brain diminishes its cognitive abilities.
Right. In fact, the thinking in the last 3 to 5 years has been rather intriguing. And the thinking now is that a person has Alzheimer's not when they're 80 years old and can't remember their name.
Yes.
A person has Alzheimer's at 30, 40, 50, 60 when the markers, the biomarkers, start to suggest that problems are in the offing.
Yes. Yes.
And so going into the cerebral spinal fluid and looking at A beta markers and tau markers,
yes.
These are now becoming rather eloquent in their predictions of who does and who doesn't have this disease. Now, this is far from a clinical refined science yet, but it's pretty clear that in the next 10 to 15 years, the algorithms for someone who's age 50 and having memory problems will involve these biomarkers, as well as memory tasks, function tasks, and maybe some other affect markers.
Yes,
so it's getting better.
Well, I mean, I guess one point to make is that as the brain diminishes its intellectual power, and age will do that, there are many different things that are impacting on it, and just one of them, I guess you could say, is the abnormal protein metabolism that causes Alzheimer's in the brain. So some biochemical, I guess, errors start to occur in protein synthesis in the brain, and then this dementia occurs. And there are many other etiologies of dementia. I mean, and so that's one. If you have an elderly parent or a relative that I guess in the audience, you take that relative in to be worked up. They'll go through a variety of different kinds of examinations, and so we want to be sure there's not any systemic etiology for this. Lots of things can cause the brain to not be as facile as it would under other circumstances. But we finally get to the point where there's nothing we can do with I guess, systemic treatment or surgery. And often what we do is people can have something called normal pressure hydrocephalus. The ventricular systems can enlarge, and as neurosurgeons, we sometimes put a little tube in the brain and take the fluid down into the abdomen where it's absorbed, and that can often improve memory, but that's another story. Well, so Dr. Hyer, when you get patients that you're trying to that come to you and you're making efforts to improve their memory, there are lots of ways that you, without medication, do you put them through sort of mental weightlifting, if I can say that? Can you? Maybe you could discuss that.
That's a good metaphor. In fact, we talk about the hippocampus, which is sort of the soul of the brain for memory, and the hippocampus will degenerate or augment, increase, depending on what you do with it. In fact, you can train older folks, 80, 85, who have very little cognitive brain reserve, so they might have less than a high school education, they might not have been intellectually curious for lots of years. You can train them in 6 months and their hippocampus actually increases in volume. And so what we've done is to look at the literature, which in the last 5 to 8 years has been sort of intriguing, and it's basically said, look, we can improve the memory and the life quality of normal older folks, age 60 to 90, by doing memory retraining and some other things, exercise, memory retraining, good diet, and a couple of stress moderating techniques. And I'm not sure we can do it with people who are starting on the decline process, and I'm not sure we can do it with mild dementia.
Yes.
So what's happened in the last 3 years is people have said, you know, there's a bunch of studies out there that are showing that if you're having memory complaints and you're into the mild cognitive impairment range, which means that you're about a standard deviation, which is a reasonable chunk, low on working memory and recall, that there are things you can do to bolster that memory up and that stave off the furies of problems. And it's more than a few studies that are suggesting this. And so what seems to be the elixir for this is a memory retraining class where you teach people, sometimes with a caregiver or a spouse there, sometimes alone, but you're doing it in a holistic way where they're not just getting training on the memory, but they're involving themselves in their whole life. that seems to make a difference. And what we've done at GNI and at Family Med is to develop a manualized 7-session memory program. We now have 120 people who have gone through this program, and we now know what works and what doesn't work because we have pre and post tests. But basically, we teach them how to concentrate. In fact, I say to them when they come in that they don't have so much memory problems, they have an attention problem. They have not been attending and concentrating in appropriate ways in their 60s, 70s, and 80s, and that's causing the trouble. So if they can retrain themselves to pay attention to things, and we teach them how to do that, then we can start to get some changes in their cognition, in their affect, and in their function. And that's what we've been able to show.
Well, that's a rather profound, I guess, statement.
Yeah.
The idea that that an elderly person that's gradually can't find his or her keys and is sinking, and the family is getting worried about the patient, that just with some memory training and some efforts at this mental weightlifting, the process could be reversed. That's a rather powerful thing. May I ask, what about the influence of caffeine, or I mean, in these circumstances? I mean, it's been said a cup of coffee or two helps. Does that play a role in this, or you drink 2 cups of coffee before the memory tricks, or not? No.
Well, caffeine does help. We don't teach that, but caffeine does help. In fact, what I've done that's maybe distinctive from other places in the country, because there are about 5 or 6 other places that are doing what we're doing. They tend to be in the Northeast and in the far West and Los Angeles. And what I've done is to basically develop this model, this manualized program, where for the first 10 to 15 minutes, I really teach them about what the data suggest. So I'm giving them what I'm viewing as empirically supported. This is not just stuff I'm making up. And so we teach them how to concentrate, and we have a method to do that. But we also teach them diet, and there increasingly is evidence, maybe as many as 15 studies on the value of the Mediterranean diet, for example.
Yeah, that's the one where you get some red wine. Is that right?
That's drink all the wine you can. Resveratrol is not too bad. Right. But the idea would be that if they can start to make changes, so you wouldn't have to marry fully into the Mediterranean diet, but maybe you can start to apply some of its suggestions, so that you're not eating meat every night and that sort of thing. But we do that, we teach them, and many of them, most older folks are into exercise, and they've learned that in the last 5 years. And there are maybe as many as 50 studies now that show that if you exercise, you actually increase thinking capacity, the hippocampus.
Well, now this is, which means seahorse, if I can remember that. Yep. That's right. I'll just throw that out as a little aside. When the many of the structures in anatomical structures were named just by what they resembled. I mean, I'll think of something else. What is? Well, I don't know. I have to think of it. But that certainly, as the brain was being sliced, there was a particular area that resembled a seahorse, and thus the name, the seahorse.
That's right. Yeah.
Another one is mammary bodies. So there's an area in the brain that resembles breasts. So there are 2 breasts. They're called mammary bodies. They're very small little protuberances. So there are little things like that throughout the anatomical dictionary. And but the idea is that exercise can actually change neurotransmitters. I mean, isn't that what we're really discussing here? Yeah. I'll just say this for the audience. The central nervous system and the neuronal system in general is like an electronic battery, and so there are electric currents that flow through there, and their transmitters are they're molecules that allow the electricity to go along in the right way. And if you have more of these little molecules, the electricity flows in a better fashion. Yes. And exercise can make the more transmitters there, and the electricity goes better, and you think and remember better. And conversely, if one gets depressed, it has the opposite impact.
Absolutely.
So just to say it this way, if one's life situation is improved, I mean, whatever. Let's say if you become euphoric, if your University of Georgia football team wins, just to use that example, then that's a slight joke, but not totally. That you're happier, you're a bit more euphoric. With everything else being equal, your memory should have some improvement. And contrary-wise, if your pet cat leaves the earth, I mean, or it's not a creature you're attached to, then you get depressed, then it might have the reverse impact.
Sure.
Is that fair?
Well, our senior citizens who are alumni of UGA might have had a depressive year this year.
I noticed that. Personally, I think I've had an impact on me.
But
yes.
no, you're right, and the idea would be that all of life throws curveballs and fastballs,
Yes.
and the curveballs sometimes end up with your cat dying or a spouse dying or something. But the hippocampus is going to respond the extent to which you respond, and we now know that with this epigenetic component that people respond in life in the way in which that's important to them. If they can make it work for themselves, then the synaptic density
Yes,
and the synaptic connections really do make a difference. And so I had mentioned memory training, and I had mentioned diet, and I had mentioned exercise, and we also teach, and these all have an impact on that seahorse, which is, these are biomarkers, and these are PET scans and fMRI and diffusion tensor imaging markers, which are very sophisticated. So they know that when Mrs. Smith is retraining or exercising or doing the Mediterranean diet, after a certain period of time, this makes a difference on her thinking. We know it from tests that we give as well as from the biomarkers that I'm mentioning. We also teach a thing called mindfulness,
Yes.
which is probably known more and more to people these days. And basically it's a belly breathing relaxation technique that allows, and it teaches people to concentrate. And remember now, that's the thing we want them to do with memory. We want them to concentrate better. And so I have them learn a technique of breathing where they do this approximately 10 minutes a day. And in doing that, they allow themselves to calm down and they allow themselves to concentrate. And there's a lot of data on that, not only with increased cognition, but it also tends to make them more patient, more observant, kind of looking at the perspective a little better, et cetera. But remember, the key we teach every time is concentration. And we have a memory acronym that we use called GULP, G-U-L-P. And GULP stands for G, get it, U, use it, L, link it, and P, practice.
Yes, yes.
And so the G is you identify something you want to learn, like I want to learn about Zell Miller's book,
right.
and I might read the inside cover, and I'll look at it and read it and about why he wrote this book and who he is and how old he is and when he was born. And then, I'm making the choice to learn from this book. Now I want to use it, so I'll read it, and I might read it again because I'm a slow reader, or I'm someone who can't comprehend very quickly, and then I will look away and say again what it is I've just said, and then I'll look back at the book and say, oh, I missed this part, and this part. They're much more likely to remember that over a period of time. And as they do this more and more, not only are they more likely to remember it, but they start doing it effortlessly. So they don't have to read it twice and 3 times. They can start to do it more quickly. And then we have the linking, the L part and the P part. The L part is linking. And we can teach someone who's 70 years of age, 75 years of age, 80 years of age, we can teach them to memorize 12 words in about 90 seconds by about the 5th session in our group.
Yes.
So that they're now taking 12 words where initially they could remember 3 or 4 in 90 seconds.
Yes.
Now they're remembering all 12 of them, or 10 of 12. And they're amazed at that.
Yes.
And we do it by the method of linking, which is effortless, and the brain sort of likes to do this. The brain loves novel, the brain loves nutsy stuff, and it does that. And so we use that method also.
So the brain actually is an active organ, is it not? It's constantly exploring, and it's attempting to unlock secrets and discover causality.
It wants to do that.
Yes, it's intrinsic in our species in all stages of life. Yeah. Well, in doing this, it's seemingly, it's good that these, I wish I could have had some of these tricks when I was in medical school. Any physician can relate the thousands of things that it was necessary to memorize. Lots of attention to memory is in medical training. But when your patients are able to do these
you know that Mercer, and UGA's new medical school, I just sat in on one of their classes and made some input. They now use the problem-based method, and Mercer's been using it. MCG now has been using it. And part of that is they make the person who is learning this, the medical student, intrigued by the case, the problem.
Yes.
And they start linking things in.
Yes.
Much like the method of linking that I was talking about. So it becomes So at the end of the week, not only do they know the pathophysiology and the cell physiology of this particular disease they're studying,
yes.
but they do it in such a way that it's kind of sexy and nice and interesting to them.
Well, you know, I think the problem with memory often is that if it's just rote memory for isolated facts, the brain has a very hard time accepting that, and it only will go in the short-term memory box. So I guess one can say there are two kinds of memory. There's long-term and short-term. So if you're any students out in the audience that are studying for their, I don't know, geography test tomorrow, if there's not any relation to these arbitrary facts, the brain will just, it won't keep it there for a long time. It'll just toss it out.
Yeah.
Long-term memory will be imprinted.
Right.
So things that are very important to you when you, like your wife's birthday, if I could say that, if you can remember that, that'll be imprinted long-term in the long-term.
Well, maybe through
That's
negative reinforcement.
A negative reinforcement plays a role too in memory, but long-term memory is a different thing than short-term memory. And I guess the point is, making memory something the brain wants to do and it uses in problem solving is an important, that's a very important part of it.
It is, it really is. And you know, memory is pretty neat when you look at it, and this is, you know, again, these first 10 minutes we talk about the newer studies on memory, and there's an awful lot of new data on memory. And for example, I look at you and I'm talking with you now, and I have a Dr. Robinson engram that is stimulated when I think of you, and that's very specific, different from my wife. I have one for her too, and it tends to start with the hippocampus, but it sort of iterates through many sections of the brain, especially the medial temporal lobe area.
Yes.
And so, and it would be for Zell Miller or whatever it is I'm focusing on. I have a specific, and it's nice to think of it that way, because if that's the case, then I only need one little cue to remember you, and it'll go right back to that engram.
Right.
So that I'm immediately focused on Dr. Robinson, who he is, you know, what he does, that sort of thing. We also know that, as I mentioned, this hippocampus thing, that memories that are more short-term, the hippocampus will hold on to for a reasonable period of time.
Right, yes.
And then over the longer term, it sort of places it someplace.
Yes.
So that you can look at this through PET scans. If I asked you, what did you do in high school?
Right.
We'd look at a very different part of your brain than if I asked you, what did you do 2 years ago?
Yes,
We're looking at more hippocampal-based stuff, which is fascinating to me. And older folks who are listening to this really become engaged when they hear this, because they realize that even though they've not been active, that they can really make a difference. This memory is very dynamic, and there's a delicious word in biology called somorphosis, which is that the rising tide really helps all boats. So that if you can get a couple boats going and the tide pushed up, everything starts to benefit from it.
Right. Well, it's interesting. I guess one can say this: a lot of the way advances take place in medicine is that maybe a person discovers one thing, and then people say, "Well, we can use it for this and this and this." And so there's been a lot of work with biomarkers in the brain using things like PET scans or there are different kinds of MRIs, spectrographic MRIs, where we can actually pick up the metabolism that's occurring in different parts of the brain. So really, one of the things that we can talk about is if people are stimulated in one way or another, they're trying to learn, we can see what part of the brain is metabolically active. And it just emphasizes the complexity of the brain. The brain is very, very complicated, and it's in many different levels of complexity, many different levels. There's also increasing notions about plasticity. So if the brain has an injury, the brain can work around that injury. So older people that might have had some degree of neuronal damage, either secondary to trauma or micro infarcts in the brain, or maybe biochemical abnormalities, that can be improved. Well, let me ask you this question: if presumably people are their memories being enhanced, the real I guess end game in helping memory in older people is to keep them in their home environment and to allow them to function in their everyday activities. So presumably, if they're they've been doing this weightlifting when you're in your classes, they've been having a fish at night instead of pork chops, and having a glass of wine instead of Jack Daniels, whatever the Mediterranean diet is. Is that going to translate into a better life, and can they in their home environment?
Well, the concept of transferability and generalizability are bugaboos. They're tough. What our data show are these facts. One, that we get people who do very well, who comply and have a little bit of skill going in.
Yes.
Those who do not comply and have less skill, we don't do as well with, and that's a problem. So of the 120, we have about 30 we did not do well with.
Yes.
One of the questions that I asked, this might seem a little controversial, one of the questions I asked when I first start the group is I'll go in and I'll sit down and I'll stand up and I'll say, who in here, by a show of hands, is not going to get dementia?
Yes.
Nobody raises their hands.
Really?
They all know that this is a horrible disease. They
Yes.
know if they don't do anything, they're going to have problems.
Right.
And they've all known someone who's died of it.
Yes.
And so people, and then you can start to engage them at that point. What are you doing now that might be problematic,
Yes,
that would
yes.
lead you down that direction? And what might you do to change it? What would
Yes.
make it worth your while to say to yourself, you know, I'm a little motivated to listen to this and to do some of the things that are being asked. And so we try and engage them.
Yes.
And again, we had 120, and about 30 we did not get maximal compliance. That's
Yes.
not I don't think that's too bad, but we still
Yes,
failed with
yes,
30.
yes.
And of those, you know, those people tended to be people that had less skill going in, so their brains were a little more impaired,
Yes.
and maybe less brain reserve, less plasticity. And the result was that we need to sort of target those people and do a better job with those people too.
Yes. Hey, what about in and maybe you can comment on this. It's very common these days to get CAT scans or MRI scans of the brain. I mean, if you have a headache and you go to the emergency room, that's going to happen. Any comments about what the impact of a CT scan of the brain that shows a lot of atrophy? Are those people going to be ones that don't do well with it, or
They probably won't. If it's at that level, then probably they're going to have more trouble.
Yes.
But typically what you'll find is that there's some atrophy which is normal for aging, say an 80-year-old.
Yes.
And that person's going to do fine. I
Yes.
mean, we can work with that person. If the atrophy, however, is beyond the norm for, let's say, an 80-year-old or an 85-year-old, then it gets a little dicey and you start to get a little bit concerned, whether it's cerebral atrophy or some
Yes,
of the
yes.
white matter hyperintensities that you're seeing. Then things get a little more problematic. And so I think we're learning now that we don't do well with people who don't comply. We don't do as well with people who are a little lower on the scale. And I think that means that we need to alter our GULP, the U part,
Yes.
where we have them do other things, where they can use it for them. Maybe that means more lists, maybe that means more support from the outside, better use of calendars, better use of devices like a telephone where they can monitor, be monitored,
Yes.
and the like. And so we're thinking about doing things like that also. We're also, you know, thinking that there are models out there that are very helpful. The one that I like a lot is at Hopkins, where they've taken Hopkins students and older folks and they just let them go into elementary schools and work
Yes.
with first, second, and third-year-old kids that are having trouble. They do well. The
Yes,
kids do
yes,
well.
yes.
The brains do better with based on PET scans and fMRIs. And so that's a nice model to think about doing here. And
Yes.
actually have the Mercer Dean very involved and interested in
Yes,
this,
yes.
and you and Dr. Ackerman and others. So we might be able to do something like that here with those that are more impaired.
Yes, well, you know, that's obviously a big challenge, particularly as the life expectancy increases. And let's see, I guess one literary figure I think of sometimes is Somerset Maugham, who was a great writer, and he was a very healthy, had the physique of I don't know what, Superman. But as he grew older, he became demented, and it was a very sad story. And that's not uncommon, is it?
No,
People
it's not.
that are physically in good shape, but they've lost their cognitive ability.
Yeah.
It's a very sad situation, isn't it?
It is, and you know, you can have the good poker hand and still lose the game.
Yes, yes,
And
yes.
Somerset Maugham did, and he still lost the game. So you might speculate that he had an APOE allele and he had some bad genes, or maybe he did things in life that were problematic, a lot of head trauma or something.
Yes,
So you just don't know. But you know, we all live, we all make choices for ourselves, and if you're going to live 90 years, you want to be able to have the best poker hand you have to make that work for you.
yes. Well, we can hope that we'll make it to 90, and if we don't, well, that's the way it goes. And if we do, we want to be sure that our cognitive facilities are still there in order to enjoy life. So, Dr. Hyer, thank you for coming, and keep up the good work, and we look forward to talking to you some more.
Thanks,
Thank you
Dr.
so much.
Robinson.
Thank you.
Thank you.
Thank you.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.